Hello everyone, this is your second lecture on health assessment. In this lecture we will cover how to conduct a physical assessment in a systematic way. The first thing we're going to assess is the neurologic system. We call it a head-to-toe assessment because we go literally from head to toe, and it helps us to stay systematic. So the neurologic system is your cerebral function, your cranial nerve function, sensory function, motor function, and your reflexes. All of these are part of your neurologic system. So in our health history, what we should have collected is, information about how they perform their activities of daily living. Do they have any dizziness? Do they have any loss of sensation? Do they have headaches often? How is their ability to see, hear, taste, and detect sensations? All about their five senses. This gives us an idea about their neurologic system, right? And then for the physical assessment, we're going to check their mental status, which includes the orientation to person, place, time, their cognitive abilities, their affect, their mood, their appearance, their general behavior, their ability to speak clearly, and ability to respond to questions. All of that shows their orientation. So when we say a person is alert and oriented times 4, we're basically saying that they're they're alert and they're oriented to person, place, time, and situation. What are the normal findings that we should see? That the patient is oriented to person, place, time. They have a clean appearance. They have an erect posture. They have a good short-term and long-term memory. They're coherent and their thought processes are coherent and logical. Abnormal findings. What are these? They indicate mental health disorder, developmental delay, brain disease, cerebrovascular disorder, alcohol and drug intoxication, or a tumor. So these are all indications of an abnormal mental status. Consciousness. We want to know their degree of wakefulness, ability to be aroused. This is described as awake and alert, fully awake. Lethargic, they appear drowsy or asleep most of the time. They're stuporous, unconscious most of the time. Comatose, they cannot be aroused with, even with the use of painful stimuli, like if you pinch on their clavicle or, they're present on the sternum, they don't wake up. They're in a coma. We can assess their consciousness with, these tools. You could use a Glasgow Coma Scale that we're going to use, in lab, and then a full outline of unresponsiveness scale, the 4 scale. So this is the Glasgow Coma Scale. So this is how we measure, like we said, every assessment we do in healthcare, we need to quantify it in order to be able to document it. So, this is a standardized scale. Best eye response, we measure verbal response, motor response, and then we calculate the total score. So comatose clients will have a score of 8 or less. Totally unresponsive patients will have a score of 3. The best response is 15, which is a normal person. Awareness, level of awareness, orientation to person, place, time. Are they aware of the situation around them and where they are, who they're talking to, why they're there? Then we want to assess their memory, immediate recall for past events. This can be assessed with repeating a series of numbers, forward and backward, and gradually increasing the numbers until the patient cannot repeat them. Ask questions about the patient's birth date, wedding anniversary, etc. These are ways you can check their memory. Sometimes you can ask them questions about, okay, who's your president? Which state do you live in? Where are you right now? Things like that, just to check their memory. Language. Their cerebral cortex controls the ability to express themselves through writing, words, or gestures, or to understand the spoken and written word. Assessment involves asking the patient to name items in the room. Following simple commands. That's another way to assess it. Read short sentences aloud. Match printed and spoken words with appropriate pictures. You know, we call injury to cortex. If they have an injury to their cerebral cortex, then you will notice aphasia, a language disorder. It can be expressive aphasia, where the person understands the written and spoken words but cannot write or speak to communicate effectively. Like they understand it, the written word, or if you talk to them, they understand, but they cannot communicate with you. That's expressive aphasia. They have difficulty and disorder of expressing themselves. Then we have receptive aphasia. This is where a person cannot understand written or spoken words at all, either. So they cannot, express or understand it. So this is receptive. These aphasias can also be combined. So they cannot express themselves, nor can they understand the written or spoken word. So this is a language deficit that we need to assess our patients for. Motor function and coordination. We want to check their balance and gait. How do we assess this? Have the patient walk across a room on the toes, on the heels, and the heel to toe. Observe their posture, balance, arm and leg movements. Be very careful though, especially if it's an older adult or if they have, abnormal gait, they don't walk steadily, then please be careful because they could fall. Posture should be erect with slight swaying in the standard position. Walking, their gait should be smooth and rhythmic with arms swinging at the sides. Then you check their coordination. Right? How can we assess this? We have the patient rapidly touch each finger with the thumb, rapidly pat the hand on the thigh, and tap the foot on the floor or against your hand. If the patient is laying down, you tell them tap their foot on your hand. Repeat the sequence on the opposite limb as well. So normal findings will be that the movements are coordinated. Abnormal findings indicate disease of the upper motor neurons or the cerebellum. This is also a very important assessment of the neurologic system. Then we want to check their sensory function, the patient's response to pain, light, touch, and normal shapes, right? So these are their other sensors, their sight, they hear, touch. So how do we assess this? With the patient's eyes closed, randomly touch the skin on the upper and lower extremities and the trunk with a sharp object and a soft object. The assessment proceeds from distal hands, our hands are distal, hands, arms, feet, or legs, to proximal, the trunk. Then close the eyes and identify familiar objects such as a coin or a key by touching them. Normal findings should be that the patient should be able to distinguish between the sharp and painful and soft to dull touch. Because when you're touching them with the sharp or soft object, you're asking them, how does that feel? They should be able to say, okay, that's sharp, or this is a soft object, right? So normal findings should be that they should be able to distinguish that, right? Abnormal findings will indicate inability to perceive pain or light touch, identify the location of the touch, identify familiar objects. These all indicate abnormal findings. Then we have the neurovascular assessment. This is, the significance of the neurovascular assessment is that it's an early identification of neurovascular impairment, and so we can intervene in a timely way. It indicates damage to the nerves and blood vessels, which can be caused by musculoskeletal trauma like falls or crashes, crush injuries, orthopedic surgery, external pressure from cast or tight-fitting bandages. Right? That's the reason why when a patient has a cast on from a fracture, we check the neurovascular status, the 6 Ps. Right? This damage can cause localized inflammation and tissue edema and leads to significantly diminished perfusion. There's not enough perfusion to that area and causing severe ischemia, severe permanent dysfunction of the affected area and loss of limb. So if they're not getting enough perfusion to the area, it causes ischemia and they can lose that limb. So neurovascular assessment includes assessing for changes in circulation, motor function, and sensation. It includes assessing the 6 Ps, which we will cover a little bit more when we talk about the musculoskeletal system. So assessing the cranial nerves. Now these are the cranial nerves. We're not going to go into detail with these, but I just want you to know that these exist and what these do. You will be covering these in block 2. Okay, So that is your neurologic assessment. Then we're going to move on to the skin, hair, and nails. Sorry. So the integumentary is composed of the skin, nails, hair, scalp, sweat, and sebaceous glands. Assessing the integumentary structure provides information about the patient's overall health status, as well as local and systemic health problems. So in the health history, we ask them about any rashes or lesions, any changes in color in their skin or hair or anything like that, other than normal aging, right? Do they have any itching, any bleeding or bruising, any allergies? How much time do they spend in the sun, and do they have any sunburn history? Their bathing routines, what products they use. You want to know if they check to see if they have any piercing or tattoos or moles. Are they exposed to chemicals in their occupational, in their environment? Or what are their mobility levels like? What's their diet like? What are their other skin practices, including cultural, skin practices? So with the hair and scalp, we start off with the hair and scalp. You assess the color, texture, distribution. The hair should be normally resilient, evenly distributed, not excessively dry or oily. Abnormal findings usually are unusual balding, we call that alopecia, and excessive amounts of hair on the facial and body, hirsutism. It's called hirsutism. Hair loss could be normal, maybe the result of chemotherapy, radiation therapy, infection, normal hormonal disorders, or inadequate nutrition. Decreased oxygenation of the peripheral tissues, especially the lower extremities, can cause a loss of hair too. So we want to keep an eye on that as well. Look at their lower extremities, see what their hair distribution is like. Excessive hair growth in people can happen with hormonal disorders. So the way to assess it is that you separate the hair to inspect the scalp for, color, dryness, any scaliness, lumps, lesions, lice, nits. They're like white eggs of lice, and they can be differentiated from dandruff or lint because they're attached to the hair shaft. And that's how you know that it's a nit and not just dandruff. If lumps or masses, when you're touching it, if you feel lumps and masses, note the location, the size, tenderness, and see if they move or not. And moving on to the skin, want to inspect the color, vascularity, and lesions. So look at the skin. Just, see if it looks normal to you, right? What are some abnormal findings you'll see there, right? You'll see bleeding or bruising, and this could be a sign of cardiovascular disease or liver dysfunction. Look for ecchymosis. It's a collection of blood in the subcutaneous tissue, and it looks like purplish discoloration. Look for petechiae. These are small hemorrhagic spots caused by little capillaries bleeding. Assess the location and color and size if you see any. Look for lesions. Is there any bruises, scratches, cuts, burns, insect bites, wounds? Assess the lesions, and if they have any, then assess them. And for size, shape, depth, location, presence of any drainage. Are they draining? Is there any odor coming from them? Look for rashes, see what kind they are. Look at the type, if they're elevated or not, where they are. Is there any drainage or itching? Assess the location of condition of body piercings and tattoos, right? And document these things in their, in their record. Palpation. This is what you see with inspection. Now when you're palpating, what are you going to touch and palpate to see? Because remember, we use different assessment techniques. What are they? Inspection, palpation, auscultation, and percussion, right? So for skin, we're going to use inspection and palpation. We inspect for all the different lesions, any discolorations, bruising, bleeding, and all of that. And now we're going to palpate. The skin is normally warm and dry, so temperature and it should be moist. If it's warm, if it's too hot, then it can indicate an elevated body temperature. If it's too cold, then it could actually indicate a lack of circulation to that part of the body. So the texture of the skin should be smooth, not rough or dry, right? If a patient is dehydrated, the texture can be dry. and loose. And you can check that by, checking, the turgor of the skin. So you'll pinch the, with your thumb and your finger, you pinch the skin. And if it's tenting, we call it T-N-T-I-N-G, then that means that they're dehydrated, right? The normal skin fold will turn to its usual shape when released. Decreased turgor will, normally found in older adults as a result of a decreased elasticity and thinning of the dermis. And then edema, look for accumulation of fluid. Palpate for edema in, their lower extremities or in other parts of their body. This could be, difficulty lifting the skin fold because it's swelling and it's tight. And the skin is shiny over the edematous area, like the area that's swollen, it's shiny. When palpated, it causes indentation. And we measure that in millimeters, right? And we press it, and if it stays dented, then that's considered pitting edema. If it's not, then it's non-pitting. Edema can be graded like it could be +1, 2, +2, +3, and we'll talk about the different levels of edema as well. Then you have skin color. What should skin color look like? Assessing the skin color. Erythema is redness of the skin, right? And this, for example, causes could be blushing, alcohol intake, fever, injury, trauma, infection. Cyanosis is bluish coloring of the skin and mucous membrane, so it looks blue. So this could happen in cold environments. Some people have Raynaud's disease. You'll see that in them. Cardiac respiratory disease. It shows decreased oxygenation. Then you have jaundice. Jaundice is yellow appearance of the skin. This can be caused by liver disease because increased levels of bilirubin. Then you have pallor, paleness of the skin. This can be caused by anemia. Then you have vitiligo, with like white patchy areas. It's an autoimmune condition. Then tanned or browned, overexposure or melatonin production or pregnancy, you have brown spots. If you notice, erythema, cyanosis, jaundice, and pallor are in red. These are keywords. Please take these notes down in your guided notes. Then we talked about hair and skin. Now let's talk about nails. How do you inspect the nails for shape, angle, texture, and color? The nail should be somewhat convex and should follow the natural curve of the finger. The angle between the nail and its base should be about 160 degrees. The nail should be smooth, and the nail base, when palpated, should be firm and non-tender. Abnormal findings, could indicate infection, painless separation of the nail plate from the nail, increased brittleness or thickness, and clubbing. Clubbing is the bulging of the last part of the finger with curved convex nails. This can be a sign of reduced oxygen in the blood. So patients who are smokers or patients who have COPD usually have these, have clubbing in their nails. So what are some age-related variations we see? Common skin variations in newborns and children include jaundice, fine downy hair, smooth, thin skin at birth, pubic hair development at the onset of puberty. But we're going to focus on the older adults. What are normal age-related variations? We have wrinkles, dryness, scaling, decreased skin turgor, raised dark areas, flat brown age spots, small round red spots, cherry angiomas we call them, fine brittle gray or white hair, hair loss, coarse facial hair in women, decreased body hair in men and women, thick yellow toenails. So these are all age-related variations. So let's move down to the head and the neck. When we're assessing the head and neck, this includes the skull, face, eyes, ears, nose, and sinuses, mouth, the pharynx, trachea, thyroid gland, and lymph nodes. The physical assessment of the structures of the head and neck provides data about the shape, structure of the cranial bones, function of the special senses, the nasal and oral structures, and any swelling or pain in the lymph nodes in the neck. Assessment of the size and consistency of the thyroid gland is performed by advanced practice professionals. The techniques we use for the head and neck are inspection and palpation. So with the health history, we should have collected any changes in vision and hearing, right, with aging. History of corrective lenses. Do they wear glasses or, other corrective lenses? Any history of allergies, any disturbances in vision or hearing, any history of chronic illnesses such as hypertension, diabetes, exposure to harmful substances and loud noises, history of smoking, chewing, tobacco, cocaine use, presence of body piercing or tattoos, history of eye and ear infections, any history of head trauma, oral and dental care practices. We want to know about that too. And so to assess the head and the neck, first the head. Inspect and palpate the head size for size and shape. It should be symmetrical. Measure the circumference. As you can see over here, we use a tape measure to measure the circumference. Normal findings show that the head and face are proportionate and symmetrical. Abnormal findings will show lack of symmetry, unusual contour of the skull. So if the face is not symmetrical, maybe they had a history of a stroke before, and that's why part of one side of their face is drooping. It indicates trauma, diseases affecting bone growth. Then moving to the eyes. You're going to inspect the eyes. You're going to use your pen light and an eye chart. You're going to inspect the eye structure, position, alignment, eyebrows, eyelids, eyelashes, the lacrimal glands, the pupil, and, inspect the eyelids for color, edema. Is there any edema, surrounding the eyelids, and is there equal coverage? Is there symmetrical? What are the abnormal findings you're going to see? You're going to find ptosis, which is drooping of the upper lid, which indicates damage to the oculomotor nerve, myasthenia gravis, or any congenital disorder. Then you'll notice entropion, inward turning of the lower lids and lashes, ectropion, outward turning of the lower lids and lashes. Or another abnormal finding you'll see is redness or drainage. That can indicate infection of the lid margins, conjunctivitis, or the hair follicles. So another thing, after you inspect the eyes, you're going to assess their visual acuity. To assess visual acuity, we use the Snellen chart, right? We ask the patient to stand 20 feet away from the chart, and we tell them to read the smallest line of letters possible, first with both eyes, then with one eye at a time, covering the opposite eye. Note if they're wearing any corrective lenses. Test their vision. 20 is the distance in feet from the chart because they're standing 20 feet away. Denominator is the smallest line read. So record the corresponding number on the side chart. So the acuity is recorded as a fraction of these two numbers, 20 feet away and the number that they can read. So for example, if they read, this is, say, the line 4 is the one that they can read the most comfortably at 20 feet away, right? So it will be 20/50. So 20/20 is considered perfect vision. At 20 feet, they should be able to read, this. Then after checking, another way to check the visual acuity is we call the Jaeger card. We test near vision. You use a handheld vision or screen, and then you use the Jaeger card and ask the patient to hold the card 14 inches away from the eyes, read the smallest line of letters, very similar to the Snellen chart, note any lenses, if they're wearing any corrective lenses, and record the score as a fraction over 14. So this is the Jaeger chart. Then we assess extraocular movements. First, you inspect the eyes, you assess for visual acuity, then you check for, any movements, extraocular movement other than normal. So measuring pupillary reaction, size, accommodation, and convergence. And we'll practice this in lab. So you're basically going to, darken the room, ask the patient to look straight ahead, and then you're going to shine your pen light, tell them to maybe look at your nose while you're checking it, and you're going to check the reaction of the pupil, right? And these are the different sizes over here. Then you're going to check for accommodation. You're going to hold a finger or a pencil or a straight object, but 10 to 15 centimeters away. You're going to ask the patient to look at the object, right? And then you're going to, move the object back, back and forth, and then you're going to like up and down, sideways. You're going to look for accommodation. Make sure that their pupils are moving. You tell them not to move their head, just, the eyes. Then you hold your fingers, convergence, hold the finger 6 to 8 inches away from the bridge of the nose, and you move your finger toward the patient's nose to assess if their eyes converge. And the patient's eyes should normally converge, like assume like a cross-eyed appearance, and that's normal. Then extraocular movements. You ask the patient to sit and stand 2 feet away, facing you, sitting and standing at eye level with the patient. Ask the patient to hold that still and follow the movement of your finger or a pen light with the eyes. And keep your finger or light about 1 foot from the patient's face. Move it slowly through the cardinal positions, up and down, left and right, diagonally up and down, and diagonally up and down to the right. But when you're doing this, just be careful, like not to do it too fast, because, it makes it very difficult for the patient to follow. Then we check for peripheral vision, have the patient stand or sit 2 feet away, facing you at eye level. Ask the patient to cover one eye with a hand or something else, and then ask the patient to look directly at your nose and fix the eyes on that spot. Cover your own eye, opposite eye, the patient's closed eye, and then hold one arm outstretched to the one side, right or left, and ask the patient to tell you where the fingers are first seen from the sides. So that shows how well their peripheral vision is, like how far away do they see the finger on their side. And we'll practice this in lab and it'll become more clear to you. Okay, so that was the eyes. Now moving on to the nose. Assessing the nose. We inspect the nose. Make sure it looks symmetrical, there's no physical damage, no bleeding, drainage, anything like that. Then you inspect the external nose, you palpate, inspect the nares with a light, examine the mucous membranes, color lesion, any, and drainage, exudate, that's drainage. Normal findings will be the nasal mucosa is moist and dark red than the oral mucosa. Abnormal findings are swelling of mucosa, bleeding, discharge. They indicate allergies or infection. Then you can palpate the sinuses. This, if you notice here on this picture, you palpate the frontal sinuses, the ethmoid sinuses, and then the maxillary sinuses. And as you're palpating them, check for any tenderness. Indicates an abnormal finding, and it could mean there's an infection or obstruction. So just gently palpate them with your fingers and note any tenderness. Then we have the mouth. Inspecting the mouth first. You inspect the mouth, and the pharynx includes the lips, tongue, teeth, gums, hard and soft palate, salivary gland, tonsils, and all that stuff. And then the tools you're going to use are pen light, tongue blade, 4x4-inch gauze, and gloves. Have the patient sit with their head tilted backwards. Inspect the mouth, lips, gums, teeth, tongue, under the tongue, hard and soft palate, both. If any abnormalities are noted, use palpation using the gauze to hold the tongue down. Normal findings will be that it's pink, moist, smooth, smooth lips. Mucous membranes are pink, moist, free of swelling and lesions. If there are any dentures, remove them to inspect the gums of the roof of the mouth. Use a tongue blade to depress the base of the tongue down to inspect the mucous membranes of the oropharynx. Normal findings. They're centered, the tonsils are centered, they move freely, are small, pink, and symmetric in size. Teeth are free of cavities and have, if there are issues, they have dental restoration. That means they have fillings and all that stuff. If the abnormal findings are pallor, paleness, any cyanosis, bluishness, any redness, swelling of the mucous membranes, any lesions inside the mouth and the lips, the swollen, any red tonsils are swollen, if the tonsils are swollen and red, if the gums are bleeding from nutritional deficits, any inflammation or infection, poorly fitted dentures, or poor oral hygiene, poorly aligned or missing, or teeth full of caries, like, cavities, white coating on the tongue from poor hygiene, irritation, or smoking. If they have a fissured tongue, that shows dehydration. Bright red tongue is seen in deficiencies of iron, vitamin B12, or niacin, or black hairy tongue, and that can be caused by the use of some antibiotics. Okay, that is the mouth. And then finally we have the neck. You inspect and palpate the neck. Includes trachea, lymph nodes, and thyroid gland. You ask the patient to tilt the head backward and forward, side to side, to assess the range of motion. Normal findings: the neck should be smooth, symmetric, and controlled range of motion. No venous distension. Like, for example, their jugular vein should not be distended. The neck vein distension indicates heart problems. Inspect and palpate the trachea. Check the position of the trachea. It should be midlined and symmetrical. Inspect the thyroid gland with the neck slightly hyperextended. Observe the portion of the neck overlying the thyroid gland. Assess for symmetry, visible masses. Ask the patient to swallow while you're observing it. Abnormal findings are the lack of symmetry, asymmetry, and large lumps or bulging indicate the presence of enlarged thyroid, a goiter, inflammation of the thyroid, thyroiditis, or cancer of the thyroid. Then you can inspect and palpate the lymph nodes in the neck for enlargement, tenderness, mobility. Normal findings are small, mobile, smooth, non-tender sinuses, usually not palpable. If they are, assess the location, size, consistency, mobility, and tenderness. Usually they're not swollen, so you're not going to feel those bulges, right? Normally. But if they are and you're able to palpate them, then make sure you assess the location, size, consistency. Are they moving? Are they tender? Abnormal findings include enlarged lymph nodes. Lymphadenopathy indicates infection, autoimmune disorders, and metastasis like cancer. So this is a picture of the lymph nodes that you're going to inspect and palpate. These are the normal range of motion for the neck. The patient should be able to do that without any discomfort or pain normally. So this is the head and neck. The age-related variations, commonly in older adults. We're going to focus on the older adult. They have presbyopia, impaired near vision. They can't see very well when things are too close to them. That's age-related change. It's called presbyopia. Then we have decreased color vision and peripheral vision, their vision on the side, the periphery. Decreased adaptation to light and dark. When you turn on and off the light, decreased adaptation to it. A white ring around the cornea. Entropion, eyelids turn inward, and ectropion, eyelid turns outward. Hearing loss. Elongated earlobes. Decreased neck range motion. Smaller, more easily palpatable lymph glands. So these are all age-related changes for the older adult. Okay, so let's move on to the thorax and the lungs. So this includes the lungs, ribcage, cartilage, and intercostal muscles. So a health history you would have collected. It identifies any health problems such as difficulty breathing, chest pain, sleep patterns, cough, sputum, environmental exposure to certain inhalants, and it includes. These are done to obtain, identify risk factors for altered health. History of trauma, number of pillows used when sleeping, history of chest pain with deep breathing, history of persistent cough with or without, sputum production, any history of allergies, environmental exposures to chemical, asbestos, or smoke, history of smoking, and if they have, how long, how many packs a day, history of lung disease in the family members or themselves, history of frequent or chronic respiratory infections. So this is all the information data you would need for the health history. So once you get the health history, the physical exam includes inspection, palpation, percussion, and auscultation. The positioning is you want the patient in a sitting position. With the head raised about 30 degrees. So let's talk about the physical exam. The physical exam can identify bony structures of the thorax, respiratory effort, chest expansion, and breath sounds. So what do we inspect? First we're going to inspect the chest. We're going to look for the color. Is it consistent with the patient's face? The shape and the contour of the chest. Downward equal shape, it should be symmetric, and, it shouldn't, it should look normal. If you look over here, the normal adult chest should look like this, right? This is what we call a barrel chest. This is normally the case in people who are smokers or who have chronic respiratory diseases. Breathing patterns, you're going to check their respirations, right? 12 to 20 breaths per minute. Abnormal findings is increase in chest size and contour. Abnormal breathing patterns using accessory muscles, for example, their stomach and other muscles around the lungs and diaphragm to breathe. So this indicates respiratory disease, COPD, asthma. Unequal chest expansion can show trauma, pneumonia, abnormal respirations, right? If you only see one side of the chest raising when they're breathing and the other not, that could be a collapsed lung, and that's something you need to investigate. Barrel chest, that's the one I had shown earlier where the chest is expanded. That's called a barrel chest. So that is what you inspect with the thorax and lungs. To auscultate, we do that to detect airflow within the respiratory tract, right? We ask the patient to breathe slowly through the mouth, and with the stethoscope on the thoracic landmarks, I'm going to show you the diagram where you're going to put the stethoscope. You're going to auscultate breath sounds in the same pattern, sequential patterns you use for palpation. You listen for the duration of a breath, and then you look for the pitch and intensity of the sound. Normal breath sounds, I'm going to pull this up right here. You're going to use your stethoscope, and these are the locations that you hear the heart sounds. Let's focus on the lung sounds. You listen through these stages. You go like in the same pattern as shown over here in the diagram, and then you're going to look for, abnormal lung sounds, for example, diminished lung sounds where you don't hear anything, or adventitious breath sounds. We're going to talk more about adventitious breath sounds. And then we're going to look for, on the top part over here, is your bronchial sounds, bronchial breath sounds. They're loud, high-pitched sounds because they're around the trachea, so they're going to be very loud and high-pitched. Then the second in the middle is the bronchiovesicular. These are going to be medium pitch sounds. And this is around this first and second intercostal space. And then finally on the bottom here is your vesicular sounds. Over here you're going to hear soft, low pitch sounds in the entirety of the lung fields. So adventitious lung sounds are your wheezing, high-pitched, continuous musical sound. Crackles, where if there is fluid in the lungs, you hear this high-pitched popping sound. Crackles can be fine, where they sound very, fine, or they can be coarse, low bubbling sounds. They clear with coughing. Ronchi, this is low-pitched rumble like a snore, right? Then you have stridor sounds, high-pitched wheezing sound. Pleural fiction rub, harsh, grating, leathery sounds. Then you have absent or diminished sounds where you don't hear anything. Those are also adventitious sounds. So those are all the abnormal ones. And if productive cough occurs during the assessment, like if they're coughing and they need to, it's productive, that means their, mucus is coming up, then, assess the sputum. Look at it, look at the color, consistency, and the amount of the sputum. Now that's what we do for auscultation when you're listening to the breath sounds. You listen to, like I said, all three, the bronchial, bronchiovesicular, and the vesicular. Now we're going to palpate. We use this to detect areas of sensitivity in the chest expansion during respirations. We look for any vibrations. We call it fremitus. Chest expansion, place hands over the posterior chest wall, fingers T9 to T10, as you can see here. Use your palm surface to palpate the anterior and posterior landmarks for temperature, moisture, muscular development, any tenderness or masses. Normal findings is that the skin should be warm and dry, symmetrical muscle development, and no tenderness, masses, or vibrations. Abnormal findings will be cool or excessively dry or moist skin, and muscles asymmetry. The muscles are not symmetrical, and there's tenderness, masses, and you feel vibrations. Those are abnormal sounds when you are palpating the chest. Okay, so let's move on to, age-related variations in the older adult. What do we see in the older adult? We see increased anterior-posterior chest diameter. We see increase in dorsal spinal curve, kyphosis. Then we see decreased thoracic expansion. Their lungs don't expand as much. And we also sometimes see use of accessory muscles when they're exhaling. So these are some age-related variations you see in older adults. So I will post the videos of the lung sounds and how to auscultate and inspect, auscultate, and palpate lungs in your Canvas course, and we will practice this even more in your skills lab. Now let's move down to the cardiovascular and neurovascular assessment. This includes the heart and the extremities. The health history will identify any leg pain, chest pain, dyspnea on exertion. Every time, are they short of breath when they, exert themselves? How they perform the ADLs, behaviors that risk cardiovascular disease, for example, smoking, lack of exercise, high-calorie diet, fats and salts. All of these will be identified in their cardiovascular health history. So let's look at this over here. You're going to look at history of chest pain, palpitations, dizziness, swelling in the ankles and feet. How many pillows do they use to sleep? Type and amount of medications they take. Any history of heart defect, rheumatic fever, or chest or heart surgery. Any personal family history of hypertension, heart attack, coronary artery disease. And then any history of smoking. Type and amount of exercise, usual foods they eat each day, changes in color or temperature of the extremities, right, your hands and the legs, history of pain in the legs when sleeping or pain that is worsened by walking, history of blood clots or sores on the legs that do not heal. So these are all very important things to gather in their health history. So let's start off with the neurovascular. The techniques that we're going to use, first of all, we need a stethoscope and, your blood pressure equipment to measure blood pressure, and a watch. And the techniques that we're going to use are inspection, palpation, and auscultation. We want the patient to be sitting or laying down supine with the head raised at 30 degrees. So the first thing we're going to check is the neurovascular status. So we have, the significance of this is that's the early identification of neurovascular impairment, so we can intervene, right? Damage to the nerves. This damage can cause localized inflammation, tissue edema, lack of perfusion, become a permanent dysfunction for them. So the neurovascular assessment includes assessing for changes in circulation, motor function, and sensation. So this will include the 6 P's. Pain, how much, the pain that they have. Do a subjective and objective assessment of it. Pallor, which shows perfusion. Do they look pale? How do their limbs look compared to the rest of their body? Assess the color and the temperature of it. Peripheral pulses, check their pulses. Paresthesias, check their sensation. Do they feel numbness, tingling, or pins and needle sensations? And if they do, what areas do they feel it in? Any paralysis with movement? Do they have any, difficulty moving or inability to move certain, their extremities? And pressure, comparison between affected and unaffected limb is important. Check for swelling, physiological response, that's a physiological response to injury. Your blood loss or ooze, assess blood loss on the dressings, if they have any dressings, or the casting material, if they have a cast on. So these are the 6 P's, and it's very important for you to remember these. So that's the neurovascular assessment. Let's look at the cardiovascular assessment. To assess the heart, this includes the neck and the pericardium. To assess the heart, you need to be able to inspect, palpate, and auscultate. So this is just a picture of the heart dissected. These are different sections of the heart, and we're going to talk more about the valves and the ventricles and all of that when we study the cardiovascular system. So what do we inspect in the neck and the pericardium? right? In the portion of the body over the heart and lower thorax, encompassing the aortic area, we want to check, for any pulsations. We want to inspect, are there any visible like a pulsation, located at the fifth intercostal space, mid-clavicular line. Are they like very visible? You see it pulsating, right? You want to inspect the epigastric area and the tip of the sternum for pulsations for the, abdominal aorta. Abnormal findings will be neck distension, neck vein distension, the distension of the jugular vein. That's an abnormal finding. Visible pulsations is an abnormal finding in these areas. And and other than the apical impulse, which may result from abnormalities of the ventricle. Now we're going to palpate. What do we palpate for? We palpate the carotid artery, medial to the sternomastoid, right here, we're going to palpate the carotid artery, sternomastoid muscle in the neck between the jaw and the clavicle, one at a time. Then we're going to check palpate the pericardium for any pulsations, palpate in a systematic way. And then you're going to palpate the jugular vein, make sure there's no distension over there. And as you're doing the carotid arteries, make sure you do it one at a time, as we mentioned earlier. This is the technique of palpating. Now to auscultate, we have the different heart sounds. We auscultate heart sounds. We start with the aortic. If I'm going to bring up this picture, we start at the aortic, we go to the pulmonic, Erb's point, tricuspid, and then the mitral, which is the apical area. And so any abnormal findings are extra heart sounds. You should hear the lub-dub, lub-dub, lub-dub. That's the normal, right? Extra heart sounds at any of the landmarks, can indicate heart disease, anemia, serious infections of the heart muscle. They could indicate dehydration or overhydration, endocrine disorders, respiratory disorders, head trauma. We call these extra sounds S3 and S4. So S1 and S2 are your lub-dub. These are normal. S3, S4, or murmurs are the extra heart sounds that we should not hear, and they're not normal. You auscultate the carotid arteries for bruits, any abnormal swooshing or blowing sounds. If you hear those over the carotid arteries, these are abnormal findings, and, they can, indicate they can indicate stenosis or occlusion of the artery, abdominal dilation of a vessel, abnormal dilation, of the vessel. Report these changes to the provider right away. So this is the inspection, palpation, and auscultation of the heart. So now let's move on to the peripherovascular. This is assessing inspecting the extremities. You inspect them first, look for color, any bruising, edema, any redness, erythema, and discoloration, hair, if their extremities are hairless, or, unless, they shaved it or something, but then any swelling, thick, or edematous areas that are hairless are concerning. Any inflammation of the vein is concerning. Pain, redness, swelling on the calf or thigh is also very concerning. Then you palpate the extremities. You palpate for peripheral pulses. We talked about the different pulse sites, right? The sites, the carotid, brachial, radial, femoral, popliteal, dorsalis pedis, or posterior tibial. You assess for capillary refill. You do this by using the thumb and forefinger to squeeze the patient's fingernail or toenail until it blanches. Normal is less than 3 seconds. When you press on it and you let it go, it becomes pale, but then it becomes pink, and the color comes back in less than 3 seconds. That's normal. Normal findings also include strong pulses, equally bilaterally. We document the amplitude, strength of the pulse on using standard scales that we discussed when we talked about vital signs. You document any abnormal findings. You have absent, weak, or thready pulses, which can indicate decreased cardiac output. Any forceful or bounding pulses that you see in patients with hypertension or fluid overload, or any asymmetric pulses, that means they're not equal bilaterally. Prolonged capillary refill, like when you press, on the patient's fingernail or toenail, their coloration is not coming back, taking more than 3 seconds to come back. That can indicate alteration in peripheral perfusion and decreased cardiac output. It's very, very important to, check that. Okay. So that is your cardiovascular, neurovascular, and peripheral vascular. Now let's move on to the assessment of the abdomen. This includes the stomach, the small intestine, large intestine, liver, gallbladder, pancreas, spleen, kidneys, urinary bladder, and female reproductive organs. The health history identifies, you're going to identify any pain, nausea, how their elimination patterns, their fluid and nutritional intake, and their lifestyle. Physical assessment will identify problems with pain, abdominal masses, presence, any presence of bowel sounds. So in the health history, you're going to collect any history of abdominal pain, any indigestion, nausea, vomiting, constipation, diarrhea, food allergies, lactose intolerance, appetite, food and fluid intake, usual bowel and bladder elimination patterns. Ask them, when was the last time you had a bowel movement? How often do you have a bowel movement? How often do you urinate? Do you have any difficulty urinating? All these questions. History of any GI disorders, history of UTIs, history of abdominal surgery or trauma, the amount and type of alcohol they ingest, right? For women, ask them about their menstrual history. So the physical assessment related to, the abdomen would be you inspect, auscultate, percuss, and palpate. Now, this is the sequence that is used, and this is the order in which we use it. We inspect first, auscultate, percuss, and palpate. Now, percussion is done by advanced practice nurses. So as registered nurses, we do inspection, auscultation, and palpation. But if you see a question that asks you what order you do it in, percussion comes before palpation. Positioning, ask the patient to empty the bladder, but, let them use the bathroom before they, start the assessment. Lay them supine on their back in a position with head slightly elevated, arms on the side, and tell them to breathe slow and deep and relax the muscles. The abdomen is divided into 4 quadrants. You have the right upper, right lower, left upper, left lower. The techniques used in the following sequence, like I said: inspection, auscultation, then palpation. So what do we do in the inspection? We look for color, the surface, umbilicus, the contour, symmetry, any visible masses and stuff. Normal findings are fine white or silver line striae, indicate skin stretching from weight gain or pregnancy. The abdomen should be evenly rounded, symmetrical, without visible peristalsis. You should not see the movement of, food in their intestines. You should not see the visible peristalsis. In thin people, an upper midline pulsation may be normal. So this over here is not normal. This is not normal. That is not normal. So anything abnormal like that, document right away. So that's the inspection of the stomach. Auscultate. In auscultation, we're going to listen to the bowel sounds. And this is the sequence that we're going to start in. It goes in a clockwise direction. You start right lower quadrant, right upper quadrant, left upper quadrant, then left lower quadrant. You're going to do 1 minute in each quadrant. Normal findings, you'll sound the frequency is about 5 to 15. Every 5 to 15 seconds, you'll hear a bowel sound, right? Hypoactive means decreased bowel sounds, right? And these can happen after abdominal surgery or bowel obstructions. Hyperactive is increased bowel sounds, and this is heard during times of diarrhea and early bowel obstruction. Then we have absent. vowel sounds where you don't hear anything. So that can indicate peritonitis, paralytic ileus. High-pitched sounds, can indicate a partial vowel obstruction. Auscultate the vascular sounds, abdominal aorta, femoral arteries, iliac, arteries for bruits, like swooshing and blowing sounds, because this can indicate stenosis or occlusion of the, veins. So this is the sequence that you start. You start right lower quadrant, go to the right upper quadrant, left upper quadrant, and left lower quadrant. So here, there, there. And that's the sequence that we use to auscultate. We always auscultate first. First you inspect, then you're going to auscultate, right? And then you're going to also auscultate the arteries, the renal, iliac, femoral, then these times, and look for any swooshing and blowing sounds that, like I said, shows occlusion or stenosis. Then we have palpation. We apply light pressure with our fingers and together, and 1 to 2 centimeters. You press in 1 to 2 centimeters, palpate each quadrant. Note for any pain. Remember, we start at the right lower quadrant, right upper, then left lower. And note for any pain, muscular resistance, tenderness, or masses. Normal findings the abdomen should be soft, relaxed, non-tender. Abnormal is when it's rigid, there are muscle spasms, there's masses, and these indicate trauma, peritonitis, infection, tumors, enlarged or diseased abdominal organs. If you notice, you also check for skin temperature, tenderness, and masses. Any, the palpation, deep palpation, you can use two-hand method. Two-hand method is usually used in obese or very muscular individuals. Palpate all the quadrants. Okay. So that is the assessment of the abdomen. Age-related variations include, for older adults, decreased bowel sounds, decreased abdominal tone, fat accumulation on the abdomen and the hips. Then finally, we have the musculoskeletal system. The musculoskeletal system includes bones, muscles, cartilage, ligaments, tendons, and joints. The health history will identify ability to carry out ADLs, data collection about pain, stiffness, ability to move. Physical assessment provides information about posture, gait, bone size and structure, joint range of motion, and then the movement of, and the muscle strength, Then techniques that we're going to use are inspection and palpation. So for the health history, we're going to collect the history about any trauma, arthritis, neurologic disorder, history of pain, swelling in the muscles or the joints, frequency and type of exercises, dietary intake of calcium, history of any surgery or muscle joints, any history of smoking. If they do, then how long and how many packs a day. Any history of alcohol intake is also very important. So when we're inspecting, we inspect the spinal curves, right? We check to see if we have the patient stand up, and you look at the spinal cord. Normal findings: concave curves, cervical, lumbar, and spine, and convex curves at the thoracic and sacrococcygeal spine. Kyphosis is common in older adults. An exaggerated lumbar curve like lordosis is often seen during pregnancy or in obesity. Scoliosis is a lateral curvature of the spine with increased convexity and the side that is curved. School nurses often first identify scoliosis during screenings, which are recommended twice for girls at ages 10 and 12, and once for boys at 13 and 14 years of age. So these are the different curvatures we want to inspect for in the spine, which are kyphosis, you have lordosis, you have scoliosis. Then you want to inspect and palpate the muscle to test the muscle tone and strength. Inspect bilaterally for symmetry. Palpate the muscle for tenderness. The normal findings are symmetrical and non-tender muscles. Abnormal finding is atrophy, where there's a decrease in muscle size, muscle loss. Tremors, like involuntary movements. Flaccidity, that means there's no tone to the muscle and they're not able to move their extremity. So those are abnormal findings. Then we have inspect and palpate joints. Inspect for flexion, extension, hyperextension, abduction, adduction, supination. These are different, areas that we inspect for. And then we palpate for abnormal findings. Normal findings mean with the joints they have full range of motion. It doesn't hurt. It's non-tender when they're in the joint areas. And then the movements are smooth. Abnormal findings will show pain, swelling, nodules, crepitation, a grating sound heard or felt when they move their joints. Then we assess the muscle strength. Shoulder flexion. The patient flexes their shoulder muscle against resistance on the examiner's hand. This over here is a picture of, they move their hand upwards and you feel the muscle strength. Then elbow extension, where the patient extends the elbow against, and then the patient flexes the elbow against resistance. This is a picture of how to check for elbow extension. Wrist extension. Then we have grip. You check to see if the patient is able to grip your hands and check bilaterally. Make sure they have a strong grip. Hip flexion, right? This is when they're able to flex their hip. Knee flexion and extension. We check their knee flexion and extension, and then ankle and plantar area. So once you do that, then, you basically inspect spinal curves, inspect and palpate the muscle, inspect and palpate joints, and assess muscle strength. And then you palpate bones. You palpate the normal contour of the bones. Normal bilateral symmetry. Abnormal findings will indicate trauma, degenerative joint disease, musculoskeletal disease, and neurological disease. Okay, so that age-related variation, What do we see in older adults? We see loss of muscle and strength, decreased range of motions. We see kyphosis, decreased height, and osteoarthritic changes in the joints. Those are age-related variations in the older adult. Okay, so we are done with the head-to-toe assessment, the physical assessment of the body, from neurologic, skin, hair, nails, head and neck, thorax, cardiovascular, neurovascular, peripheral vascular, abdominal assessment, and musculoskeletal. Please look, I'm going to post this Genially and this video in your Canvas. Please look over the Genially and gather all your information, fill out your guided notes, and we will practice this assessment in your skills lab.